for her decision making and all. I welcome you, madam. And also, I would like to welcome IAP President of Kerala, Shimmi sir, the State Postgraduate Clinics Coordinator, Mohandas sir, mentor and the Head of the Department of Pediatrics, ICH Kottayam, Darli madam. Then IAP Kottayam President Barendra sir, Secretary Dr. Sumita, Jose sir, Purushothaman sir, all the senior teachers, senior pediatricians, colleagues, the presenter Dr. Adarsh, and all other postgraduate students in this academic session. And now I invite Dr. Mohandas sir, the State Coordinator of PG Club, to say a few words, few more words.
Good evening. It is a very pleasant moment for me to have Lalita Madam here. Lalita Madam is my teacher, my thesis guide, and my mentor. So, good evening, Madam. And it is really a happy occasion to see that so many senior faculty members, Srinivasan sir, Sushma Madam, Purushothaman sir, and so many. And probably as you become more and more senior, you become more interested in academics. That's the feeling we are getting. So it is very happy to see this sort of audience. So I'm not wasting any time. I would like to invite Shimmi sir. Shimmi sir, no. Or I would like to invite Anandageshan sir to say a few words.
Very good evening. Respected State President Dr. Shimmi, Treasurer Dr. Ranjit, and the senior faculty members Dr. Lalita Madam, Sushma Madam, Srinivasan sir, KK Purushothaman sir, and Dr. R.K. Agarwal. And also, I think we can see more seniors than PG students. Everybody is learning through our PG club. And I would like to congratulate Dr. Mohandas and the entire team behind this PG club because we are regularly conducting it. I think last week we had, because of the Easter and Good Friday, we didn't have any meeting. So again, we are again back again. So once again, I would like to congratulate the entire team and wish the program all success. Thank you.
I would like to invite Ali Madam, the today's mentor, to introduce the speaker. Madam needs no introduction still, and also the case.
Good evening, everyone. It's a pleasure to introduce Lalita Madam. Actually, she doesn't need any introduction to this platform, this meeting. And Madam, currently she is the principal of Kottayam Medical College and also the professor of pediatrics there. And Madam was a former professor and HOD of pediatrics at SAT Hospital, Thiruvananthapuram. And she's a very good clinician and also a very good teacher. And I don't have many words to introduce her actually because everyone knows her very well. So today's case is presented by Dr. Adarsh. We'll be presenting one of our difficult cases, and Madam very happily agreed to be the lead discussant also. So over to Madam to take up the discussion. Thank you.
So good evening, one and all, and thank you, Rali, for your generous introduction and the compliments. And I'm also happy to see all the senior members, especially Sushma Madam. Good evening, Madam. And then Srinivasan, Purushothaman, and the Padmanabhan, everyone. I'm so happy again. Mohandas, as he said, he was one of my favorite students as well. And also Thomas. So I think without wasting much time, as Dali has said, it is really a difficult case, but we'll try to analyze it. No, it is mainly the approach rather than the diagnosis that we are going for. So with this... With this, may I introduce, the presenter, I think Dr. Akash, I just forgot his name.
Thank you, ma'am. Thank you, Lalita madam. Good evening, everyone. First of all, I would like to take this opportunity to thank IAP Kerala and IAP Kottayam for allowing me to giving me this opportunity to present this case. I'll be presenting the case of baby X, whose date of birth is 23rd August 2023, age 7.5 months. He's a male baby, hailing from Nedunkandam, Idukki. Informant is the mother and the history is reliable. The date of current admission was 11th of March 2024. The date of examination was 3rd April 2024. Chief complaints: the baby already had history of multiple hospital admissions in the past for respiratory complaints and currently presented with cough for 2 days and fever for 2 days and breathing difficulty for 1 day at the time of admission to our hospital currently. Moving on to the history of present illness, baby developed exacerbation of cough in the morning, which was progressive, increased at night, and associated with nasal discharge, which was mucoid in nature. Baby developed fever later in the afternoon, which was high grade, intermittent, relieved on oral medications, but again recurring. And next day morning, baby developed breathing difficulty in the form of fast breathing as well as chest and drawing, with no diurnal or postural variation. And there was also history of a rattling noise complained by the mother. Since the baby was on tube feeds, I'll be coming to that later, there was no history of any feeding difficulty. There was no history of any bluish discoloration noted, no history of poor activity or abnormal movements, no history of vomiting or loose stools, no history of reduced urine output, and no history of any contact with similar complaints. Baby was initially admitted in ward and started on O2 therapy with IV antibiotics.
Akash, can you go back to the previous slide?
Yes,
Why did you ask for this poor activity and abnormal movements?
Madam, based on the chief complaints, the child had cough, fever, and breathing difficulty. So there was a possibility of a lower respiratory tract infection, probably pneumonia. So to categorize the severity of pneumonia, I asked for the features of severe pneumonia, which was lethargy and seizures.
Okay. What about the vomiting and loose stools?
Madam, vomiting actually I meant for persistent vomiting, and loose stools as a accompanying symptom I asked to look for any other system involvement.
Okay, that means you are analyzing the history to give a clue and to indicate the severity of the illness, right?
Yes, ma'am. Yes, ma'am.
Okay, carry on.
Baby was initially admitted in ward and started on O2 therapy with IV antibiotics and bronchodilators. Breathing difficulty worsened by day 7 of hospital stay. He was shifted to PICU, started on NIV support, and on day 12 of hospital stay, weaned off to O2 via prongs. However, the breathing difficulty again worsened by day 15 and was started on HFNC, again weaned off to room air by day 18.
Or a minute, Akash, are you using two devices? Echo virunu. If you're using two devices, just switch off one.
Okay. Madam, is it okay now?
I will just continue, then we'll know. No, seems to be okay.
Past history. The baby had history of multiple hospital admissions since the age of 2 months of age. Coming to the first admission, it was when the child was at 2 months of age, and the chief complaints were fever, cough for 4 days, followed by breathing difficulty for 1 day, for which the child was given IV antibiotics, which was later switched to oral antibiotics for a total of 7 days, and the duration of hospital stay was 6 days. Next was the second admission, which was at 3 months of age, and the baby had chief complaints of fever, cough for 2 days with breathing difficulty for 1 day, for which the child was again given IV antibiotics for 5 days, and the duration of hospital stay was 8 days. After this, the next admission was at 3.5 months of age, and for which the child had chief complaints of fever, cough, breathing difficulty for 2 days, and in this admission it was associated with poor activity for 1 day, for which the child was admitted in PICU. In view of poor activity, CSF study was done and was found to be normal. The baby was started on IV antibiotics and put on NIV prong support due to persisting distress and reduced O2 saturation. During PICU stay, the baby was noted to have history of one episode of abnormal jerking movements of the right upper limb, which had an approximate duration of 2 minutes. Following this, an EEG and MRI brain was done and was found to be normal, and there were no further history of seizures. Meanwhile, a virology testing was done for this current complaints, and the child was found to be positive for adenovirus. And due to recurrent episode of hospital admission, this being the third episode, a pediatric cardiology opinion was sought, and the echo was found to be normal. A pulmonary medicine opinion was also sought, and they advised to start the child on IV steroids, which was later tapered to oral steroids. And a HRCT thorax was taken, and they were informed to have pneumonia changes in both the lungs. In a blood culture testing also showed fungal growth and started on antifungal therapy. And immunoglobulin assay was done and found to have reduced IgA with normal IgG and IgM. Towards the end of hospital stay, the baby was attempted on oral feeds, but the breathing difficulty worsened, and hence the child was put on tube feeds. The baby was gradually tapered from the O2 therapy and then weaned off to room air and discharged with oral steroids, the total duration of stay being 36 days. The next admission was at 5 months of age, for which the child had chief complaints of cough. Actually, the cough was persisting from the last admission. And along with this, the child developed fever with rash and breathing difficulty of 1 day duration. The rash initially started on the face and then progressed to the trunk and limbs, for which a fever with rash surveillance was done and found to be positive for measles infection. The baby was admitted in PICU, started on IV antibiotics and O2 supports, and also given vitamin A. On day 4 of hospital stay, however, due to worsening distress, the baby was intubated and mechanically ventilated. A CCT thorax was done during this hospital stay, and they were informed to have some widening of airways in the lungs. A genetic testing was also done and found to be normal. And by this hospital stay, and history of inadequate weight gain was being noted. The baby was weaned off to room air over the course of hospital stay and discharged with tube feeds in this current admission, and the total duration was 44 days. So this is the overall summary of the total admissions the baby had. In between the first and the second admission and the third admission, the baby was relatively asymptomatic. However, from the admission 3, that was from 3.5 months of age, the baby had persisting symptoms in the form of cough, breathing difficulty, and fever, with cough persisting in between the episodes. And the current admission was at 6.5 months of age from 11th of March 2024. There was no history of any foreign body ingestion or trauma. There was no history of forehead sweating or suck cycle. There was no history of any other noisy breathing. No history of recurrent loose stools or greasy bulky stools. No history of reduced movements of limbs. No history of any skin infections or any ear discharge.
Can you be a little more elaborate on that?
Madam, history of foreign body ingestion or trauma was to look for any foreign body obstruction of the major airways, which can result in a persistence of symptoms despite any therapy.
What is the age of onset of the initial symptoms for this baby?
Initial symptoms was at 2 months age.
2 months of age. Is it common for a foreign body?
No, madam. 2 months of age, it is relatively uncommon.
Except? There can be a rare situation where still you have to think of the possibility of a foreign body, though it's not very common.
Lipoid pneumonia, which can be given by the...
That is different. This is a foreign body ingestion or aspiration. Does the child have an elder sibling?
Yes, madam. An elder sibling is there.
So elder sibling can... how old does the baby?
Now the baby is... the child is... elder sibling is 3 years old.
So I think that can happen very rarely. The elder sibling can put in something. Otherwise, it's a single child and all this foreign body ingestion is not very relevant as far as this child is concerned, where you consider a recurrent bar a persistent respiratory tract infection. Okay, right. Okay. The second point is mainly for?
Looking for any cardiac, suspecting any cardiac lesions, which can cause recurrent episodes of breathing difficulty.
Okay, this is mainly for a cardiac failure, no? Sacral cycle and forehead sweating. Yes. Okay, right. Then what do you mean by no other noisy breathing? So by that statement, it means that this child has some noisy breathing.
Madam, during the episodes of respiratory infection, the mother was complaining of rattling noise mainly.
What do you mean by that rattling?
Usually it is like the mothers explain in the Malayalam term of kuru kurupu. That is mainly there will be on touching the chest, there will be some rattling nature which could be felt.
What are the usual noisy breathing that we generally account for?
One is rattling. The other one can be snoring, which can be present, madam.
No, the commonest noisy breathing? Other than
Stridor.
Stridor
Can be present, which can be because of any obstruction of the major extrathoracic airways.
Okay. Other?
Uh,
Maybe I think Akash will go to the other students also. Venki, which are the usual noisy breathing that you hear when your child present with a respiratory infection?
Mostly stridor or a
Stridor.
Stridor.
Noisy breathing. It's such a simple question. One is stridor. The second is?
Maybe present with grunt.
Grunt, right?
Stridor.
But that is not the commonest.
Snuffles,
the commonest is?
Snuffles.
Wheeze. If you ask the noisy breathing, it's a wheezing and then stridor, then grunting, and then only comes your rattling. And then what else you said, Akash?
Snoring.
Snoring. Okay. Okay, right. Thank you, Vinky. And then why did you ask for a recurrent loose stools and greasy stools for this child?
Since the child is having persistent lower respiratory infections, madam, I wanted to look for the condition of cystic fibrosis, which can also have other systems association. In the GI system, it can cause recurrent loose stools and steatorrhea. So I asked for greasy bulky stools.
Okay, that. What about this reduced movements of limbs?
Ma'am, that was just to rule out any paralytic conditions, madam. Mainly like any myotonic dystrophy or any muscular dystrophies, which can present beyond the newborn period and can cause some.
You mean to say that neurologically handicapped children?
Handicapped.
Because of that recurrence. So rather than putting it as a reduced movement of the limbs, some neurological handicaps, right? Okay, skin infections and ear discharge for?
Recurrent episodes of respiratory infection, I wanted to look for other systems involvement in the form of skin infections and ear discharge, which can be seen as part of immunodeficiency disorders.
Okay, continue.
Moving on to the antenatal history. It's the second child of a non-consanguineous marriage born to a 22-year-old mother. The elder sibling was a full-term normal vaginal delivery who cried soon after birth and had a birth weight of 2.85 kilogram. A male child who is currently 3 years and well growing. First trimester, the UPT test was positive after 4 weeks of amenorrhea. It was a booked case at Nenagandam Taluk Hospital. There was no history of excessive vomiting, bleeding PV, fever, thrash, or any drug intake or radiation exposure. Dating scan was done and folic acid tablets were taken and TD2 doses were taken. Second trimester, quickening felt by 20 weeks of gestation. There is no history of gestational diabetes, gestational hypertension, or hypothyroidism. Anomaly scan was found to be normal and the iron and calcium was taken. Third trimester, continued to perceive fetal movements and no history of any bleeding PV, leaking PV, or no history of UTI. Late scan was found to be normal. Perinatal history, it was a term and emergency LSCS in view of cord around the neck. The baby cried soon after birth with a birth weight of 2.84 kilogram and the baby was breastfed within 1 hour of birth. The urine and meconium passed within 24 hours. There is no history of NICU admissions and no history of any poor acuity or feeding difficulty complaint at that time. The baby was discharged on postnatal day 5 and there were no significant events till the age of 2 months. Baby was active and feeding well.
Okay, hold it, Akash. So when a child has got or a baby is brought with a recurrent respiratory tract infection, what are the important points that you elicit in the perinatal history? And can you elaborate on that, Divya? Divya, are you there?
Yes, madam.
Okay. He has almost completed, but can you elaborate it? The importance of certain points in this slide. Baby presenting with the recurrent respiratory tract infection.
In the perinatal history, any history of postnatal period, any history of during the perinatal period, any history of meconium stained amniotic fluid, or during the postnatal period, any respiratory distress soon requiring prolonged ventilation or oxygen support.
Yeah, especially a preterm baby requiring an NICU admission, requiring ventilation. What is the sequelae that you are referring to?
Bronchopulmonary dysplasia.
BPD. Nowadays being referred as, we use the terminology BPD, bronchopulmonary dysplasia before, but nowadays we use the terminology chronic lung disease of infancy. Right. So that's almost a, but only thing that okay, that is one. Then what are the other points in the history that may give you a clue regarding the etiology? One is a BPD or a chronic lung disease.
Any structural malformations?
No, the history.
Uh,
Okay, you can elaborate on that. What do you mean by structural abnormality and how does it manifest?
Like congenital lobar emphysema.
What is there in the perinatal history?
Antenatal scans may be abnormal.
Okay, now you have gone to the perinatal history, antenatal scans. Okay, right. Okay, going back, Akash, why did you say all these? What is the importance of this urine and meconium pass within 24 hours? Is it just your routine statement, or does there is any importance here as far as this case is concerned?
Madam, in this specifically, I asked for the meconium passage because any delay in the passage of meconium is a predictor which points to the development of cystic fibrosis.
Yeah,
So
because
I asked,
any child with a recurrent respiratory tract infection and that to progressing, I think one of the possibility that you have to consider is a cystic fibrosis. So a delay in the passage of meconium is very important here. And if there's a history that may give, that may point to the possibility of a cystic fibrosis. Okay, right. And also suppose this baby gives, it's a term baby, no, emergency LSES. If this baby had developed a transient tachypnea of the newborn and which slightly worsened, term baby, not a preterm, and required some few days of an ICU stay. Does that give you any clue?
Madam, transient tachypnea of the newborn can be pointed to primary ciliary dyskinesia.
Yeah, so there are so many points. If you take a detailed history in the perinatal, that may give you a clue also, right? Okay, go ahead. So the first 2 months after this, the baby was doing perfectly all right. And then the baby started having this. We'll go back to the history a little later. You can continue, complete with the history, and then we'll go for the detailed discussion of the each episodes. Go ahead.
Okay. Moving on to developmental history, gross motor, net control was attained by 6 months and rollover currently not attained. Fine motor, the baby attained bidextrous reach by 5 months and unidextrous reach by 7 months. Social, the baby attained social smile by 2 months and recognizes mother by 3 months and stranger anxiety developed by 7 months. Language, the cooing was developed by 3 months, laughs allowed by 6 months, and monosyllables started by 7 months. Vision, the baby follows light and fixes near objects, and hearing turns head towards the source of sound.
Overall, what do you think? What is your
Overall,
comment about this developmental history overall?
and overall, I feel there is some motor, especially the gross motor, appears to be somewhat delayed compared to the other domains.
Yeah, it's only some delay of the motor, mainly the gross motor delay. Can you account for that? Because this baby constantly inside the wards, I think, for the last 6 months. So that per se can cause this much of a developmental, means at least motor delay, provided all the others are normal. Okay, go ahead. So,
diet history, baby was exclusively being breastfed till 4 months and then started on tube feeds since 4 months due to the worsening of respiratory distress. Baby has been on mother's milk till 5.5 months and then later started on formula feeds. And from 6.5 months, baby was started on Nestum feeds. And as per the 24-hour recall method, before the current admission, the baby had a total calorie intake of 518 kilocalories per day, with against an expected of 670 kilocalories and a deficit of 152 kilocalories per day, and a total protein intake of 13.2 grams per day.
This baby was put on 2 feeds, but still then why there is a deficiency? Even 2 feet the baby was not tolerating, or is it because of the decreased provision by the parents?
The decreased by the parents, madam. Like, so during the current admission, we actually hiked the feeds. So currently the baby is receiving around 90 ml formula feeds and 5 scoops of Nestem feeds for 3 times daily.
Did you ask them whether there is any particular reason for the mother to give lesser amount? Is it because of some issue with the respiration or some issue? Nothing.
The mother did not specify anything.
Okay, go ahead.
Immunization history. At birth, BCG, OPV, and hepatitis B was taken. The birth weight was 2.84 kilogram. At 6 weeks, OPV1, Penta1, Rota1, IPV1, and PCV1 was taken, and the weight was 4.25 kilograms. By 10 weeks, OPV2, Penta2, Rota2 was taken, and the weight was 5.35 kilogram. And by 6 months, OPV3, Penta3, and Rota3, IPV2, and PCV2 was taken by 6 months of age, and there were no history of any adverse events following immunization.
So immunized for the age as per the national immunization
schedule. Yes, ma'am.
Okay, go ahead.
Moving on to family history. There was a history of contact with TB in terms like the baby's grandmother was admitted in MCH Kottayam recently. That was during the current admission of the child and was found to have some fluid in the lungs. And the sputum of the grandmother was tested negative for TB. And fluid tested showed some lymphocytic exudate with increased ADA and was found to be negative for TB. So the grandmother was clinically diagnosed as an extrapulmonary TB and started on ATT since 13/3/2024. A biopsy was taken from a thickening from the lung wall, and the report is currently being awaited. We had done already a gastric aspirate test. However, on attaining a strong positive history again as a contact, we repeated the test. It was found to be negative.
Okay, Akash, going back. Or somebody else can answer. What do you mean by contact? What is the definition of contact with TB? Arati, are you there?
Yes, madam.
What do you mean by contact? What is the definition?
Madam, a household contact means contact with the primary index case within 7 days of contact.
7 days. What is that? No.
Sorry, madam. Within 1 month of detection of TB, madam.
No. Akash?
Madam, household contact means there should be either 1 or more night stays or extended daytime stays within 3 months of time of diagnosis of tuberculosis.
Okay, that is different. Normally we say what type of TB? Contact with a
Pulmonary TB.
Pulmonary TB, and that too with a sputum positive pulmonary tuberculosis, either in the household or in the immediate neighborhood. And then how much is significant is the contact? That is what you have been elaborating to. So generally we say contact with the index patient should have a pulmonary TB and that too a sputum positive TB within the last
3 months.
No.
2 years.
In the last 2 years.
Oh.
Within the last 2 years. So that is the contact. The other thing is different. But of late, of the latest revised guidelines have also added that you can even consider as a significant contact for index case is even an extrapulmonary tuberculosis contact with an extrapulmonary case also if the baby is symptomatic. Got my point?
Okay.
The baby is symptomatic as in our child, even if there is a contact with an extrapulmonary tuberculosis, we can take it as a contact, assuming that the extrapulmonary case might have some hidden pulmonary lesion.
Yes.
That is the latest revision. So that is one aspect. Do you think how far reliable is the tuberculosis here for the grandmother? Normally, we make a diagnosis of tuberculosis. To make a confirmatory diagnosis of tuberculosis, you should have a
presumptive TB.
You should have a tissue diagnosis, right? You should somehow or other demonstrate the tubercle bacilli,
Yes.
either by a CBNAT or by NGIT or some sort of a biopsy or something. But here, the grandmother, what do you mean by that fluid in the lungs means you Pleural
Fluid,
effusion.
pleural effusion. Yes.
Pleural effusion. The sputum is negative for tuberculosis, but pleural effusion and the fluid tested is lymphocytic. The only point here is an increased ADA, right?
Yes, ma'am.
Otherwise, suppose I say it's a malignancy.
Yeah, it is also possible, madam. But then a cytology was also parallelly done, and then it was found to be negative.
It's found to be. So I think we have to take this diagnosis with a little pinch of salt. Okay, we can keep it aside, but it's not a very straightforward case of a contact with TB. And this ADA levels high also, it's not that very sensitive. Anyway, but we keep that inside, but it is not that as a significant contact as generally we used to think. Okay, right.
Okay.
Anyway, the result is waiting for the biopsy report.
Biopsy. Yes. Yes.
Okay, right. Go ahead.
The elder sibling is currently a 3-year-old boy, has no history of any recurrent episodes of hospital admission. No, there is no history of recurrent episodes of hospital admission in other family members. No history of any loose stools or passage of greasy, bulky stools in the family. No history of any congenital heart disease in the family. No history of any neonatal or early infancy deaths in the family.
Hold on, Akash.
Yes.
Elder sibling was normal. No history of recurrent episodes, greasy cells. Okay, what is the last sentence for?
Madam, any unexplained deaths in the family could also be a pointer to the congenital conditions.
Like?
One could be the congenital lung malformations. Then the other possibility could be cystic fibrosis and primary ciliary dyskinesia.
Okay, right. It may be some immunodeficiencies also.
Yes, ma'am.
Right?
Yes, ma'am.
Go ahead.
Socioeconomic history. Father is educated up to 10th standard, currently a driver. Mother educated up in pharmacy and currently is a homemaker. Lives in a Pakka house. There is history of overcrowding. The 9 members are occupying 2 rooms. History of passive smoking exposure present in the paternal grandfather. No history of any pets or dusty surroundings. The drinking water supply is from public water supply, and the monthly income is rupees 25,000 and belongs to lower middle class as per the modified Kusami scale 2020.
What are the 2 important risk factors in the socioeconomic history, Venki, which make even a normal child predisposed for recurrent infection in this socioeconomic history?
Any history of overcrowding, smoke exposure?
Yeah, definitely there is a history of overcrowding. So that makes even a normal young baby more prone for infection. Another point is?
Any smoke exposure or any history of pets in the family or any history of dust or
Here actually no pets, but there's a passive smoking. So there are 2 risk factors which make this child even otherwise more prone for respiratory infection. That also we have to keep in your mind. Okay, go ahead, Akash.
The summary of the case. This is the 7.5-month-old male baby with gross motor delay, immunized for AIDS, having her recurrent episodes of lower respiratory tract infection initially, followed by persistent respiratory symptoms since 3.5 months of age, with the history of inadequate weight gain, history of worsening on oral feeds, history of infection with adenovirus and measles virus, and a history of suspected contact with TB.
So do you want to give that much importance for the gross motor delay? If you think it's mainly a gross motor delay, then the whole approach will be different. A child with a delayed motor development and then recurrent aspiration. So I don't think that much significance has to be given for the gross motor delay. You can mention that then. So here you have a 7-month-old baby with history of having recurrent episodes of lower respiratory tract infection, followed by a persistence of the respiratory since the last 3 months with inadequate weight gain and worsening on feeds. Right?
Yes, ma'am.
History of infection with adenovirus and measles virus. Okay. From the summary, what are your possibilities, Akash? History.
Madam, there is specifically...
Initially, what do you think is the initial episode here? How long did the hospital stay for the initial episode?
Was 6 days.
6 days. And it started with a?
Cough, fever, followed by a breathing difficulty.
Cough and?
fever,
After 2 days or something, the child developed a difficulty in breathing. This is the usual, typical that we see. It looks like a
acute reactive airway disease, bronchiolitis could be a possibility.
bronchial. Don't say reactive airway disease for the first episode in a 2-month-old baby, right? It looks like some viral and most likely bronchiolitis, even though the bronchiolitis generally starts a little more later. Okay. From that, the baby had recovered, right?
Yes, yes, ma'am.
Completely.
Yes, ma'am.
Okay. Then after?
After around 1 month, after around 1 month, the
After
baby
1
had
month.
another.
But that too also was not very significant, right?
Yes, ma'am.
How many days was the hospital stay?
The hospital stay was for 8 days, ma'am.
8 days. Again, did not require any
Oxygen,
ICU
ICU stay. Yes, ma'am.
Second one required ICU stay.
No, madam. No.
No.
They did not require.
Okay, that was 8 days. Then the third one was
36 days duration.
okay, from that onwards, and that was the where you said some in the third episode is the adenovirus.
Yes, madam.
Okay, how was it tested? How was isolated? Is it a PCR, nasopharyngeal swab and PCR or some antibody?
It was nasopharyngeal swab PCR.
Nasopharyngeal.
It was sent, yes, ma'am. It was sent to NIV.
Okay, human adenoviruses can sometimes lead on to a significant sequelae. What do you mean by that? What are the usual sequelae of an adenoviral infection in a young baby?
Adenovirus can itself lead on to viral pneumonia, madam, which can also be complicated by sequelae like bronchiolitis obliterans, which can stay for prolonged periods as like till 12 months or so.
Okay, so that is one possibility that we have to think here. First 2 episodes may be the usual episodes of what a bronchiolitis like picture, but then the baby had developed an adenoviral infection, and adenoviral infection pretty severe from the history, right? Requiring an ICU stay and the respiratory support. And of course, following an adenoviral infection, the complications like bronchiolitis obliterans, organizing pneumonia, even that for whoop. Whoop has been described typically. I'm not telling that this may be, but still that we have to consider the possibility of that. And then the 4th episode, it is the 4th one, the child had a measles, or the 5th? Fourth one, right?
Fourth one, yes, ma'am.
Okay. How do you make a diagnosis of a measles? Was that really measles?
Madam, from our fever with rash surveillance, usually an IgM of the blood will be tested for measles.
Clinically?
Clinically, initially there will be a prodrome of symptoms, and there will be development of fever also during the prodrome. And
with the fever rash surveillance, what is the definition? What are the important 3 criteria to make a diagnosis of measles? The fever rash surveillance, say.
Fever.
Which are the 3 C's?
Fever. Coryza, conjunctivitis.
Cough, coryza, conjunctivitis. Because without cough, we cannot make. And of course, the rash. But this baby, at the age of 5 months, no, if I remember, developed a measles.
Yes. Yes.
2nd, 3rd, and 5th month, right?
Yes.
If the baby develops a measles at the age of 5th month, normally the baby may not have the typical full-fledged picture. There may be some modified measles. Why?
There will be transferred immunoglobulins from the mother also.
There may be maternal antibodies may be there in the baby, so they may get a modified picture. So that we have to. So this baby had a superadded measles and history of contact with tuberculosis right now. So now what are the possibilities that you think, Akash, here?
Madam, one, like you said, adenovirus itself can have a prolonged sequelae in this child, which caused a persistence of symptoms. The other point is worsening on oral feeds is present, madam. And there is also
a very important point. So, right. So one possibility that you say is the bronchiolitis obliterans, right?
Yes. Yes, ma'am.
Okay. The second one is, that's very important, especially there is a history of, that's a very, very important point, history of worsening and feeding, so that the child was put on tube feeds on the 3rd episode. And after that, continuously, even at home, the child is on tube feeds. Am I right?
Yes, madam.
Okay. So what are the conditions you think of when there is a worsening or respiratory distress while feeding and the child manifesting with a recurrent respiratory?
It could be any congenital anomalies in the airway, madam, which could be
Like
a cleft palate itself can be a risk factor, or there
cleft
can
palate, what does it do?
be there will be
Aspiration.
the aspiration
When
into
say
the
recurrent aspiration syndromes, okay, one may be due to the cleft palate, but there is no history, but you have to examine, right? Aspiration syndromes. One is cleft palate. Second,
presence of a tracheoesophageal fistula, a communication between the two.
TF, right?
Then any oromotor incoordination, pharyngeal incoordination, which usually is seen in preterm babies.
Okay, this baby is not preterm. Any other? Baby manifesting with recurrent respiratory tract infection and each two worsening with feeding. Okay, one you said structural anomalies like cleft palate, missed one recurrent aspiration. Second, of course, agree, tracheoesophageal fistula. Which are the other conditions? Feeding related.
GER can also be a possibility.
Third, GRD. You can say gastroesophageal reflux disease can then
a laryngeal cleft.
Laryngeal cleft, okay, maybe. Or something called as dysfunctional swallowing. Incoordinated, as you said, this is more so in a neurologically handicapped children and all, but swallowing dysfunction syndrome. That is, normally there is an anatomical and a developmental coordination, which may not be there in some babies. And this is more so in developmentally deviated children, but can happen in normal children also, especially so young. So swallowing dysfunction syndrome, that can also lead on to a recurrent aspiration. And is there any history of, because this child had to be given an IV and then HFNC, is there any apparent life-threatening events? What do you mean by life-threatening events, and what do you call them now? Is it a life-threatening event, or, what do you mean by life-threatening event? Child suddenly goes in for an apnea, color change, tone change, especially related to the feeding or something. Is there any like that event? Okay, can you tell me a few conditions where you can have a apparent life-threatening event in relation to this picture? Now it's called as BRU. What is BRU?
Brief resolved unexplained events. Brief resolving
unexplained events. Formerly, we used to call it as an apparent life-threatening events. So can you just think of one or two conditions, that is a baby presenting with respiratory illnesses with an apparent life-threatening or an apnea? Which condition?
Any micropnea, retrognathia?
Okay, Robin, and then going in for cleft palate, but more than that.
Aspiration due to GER itself can be risk factor.
GRD, okay, right. Or some conditions where have some airway malicious.
Tracheomalacia.
Like tracheomalacia, where there's a lot of pooling of secretions, and the child may sometimes aspirate because there's a stagnation of secretions. Or in the cases of a whooping cough, say for example, young baby, the cough may not be that predominant. The child just manifests with, the younger one, instead of whoop, they may just go in for an apnea. Right. So it is very important for you to analyze that history also. Is there any apparent life-threatening events as evidenced by some apnea or color change or tone abnormalities, limpness like that? So that's also very important. Okay. So one cause, especially if you give that much of importance for feeding, then aspiration syndromes, you have to rule out at tracheoesophageal fistula, GERD, and then airway malicious, etc. Okay, then. So these are the two possibilities. Any other possibilities from the history that you can consider? Initially recurrent and now persistent. What is the difference between these two, Akash? What do you mean by a recurrent pneumonia? What do you mean by a persistent pneumonia? This kind of.
Recurrent pneumonia means there should be presence of at least 2 episodes over a period of 1 year, or 3 episodes in any period with clinically well episodes in between.
And not only clinical.
And radiological clearance in between.
There should be a complete radiological clearance in between. This is in opposite to persistent pneumonia, where
there will be persistence of symptoms in the form of clinical as well as there will be absence of radiological clearing, usually for a period of more than 1 month.
Okay, this is what we are discussing in relation to the lower respiratory. What do you mean by recurrent respiratory infections in relation to the upper respiratory infection? How many upper respiratory tract infection can have a normal child can have? Younger one, say between 2, 3, 4 years. You might be seeing in the OPD so many cases, right? So a younger one, say 2 or 3 years, can have upper respiratory just like rhinitis, cough, condor, even up to 5 to 6 times per year. And more younger the baby, and if there is a school-going child or the baby is attending daycare, this frequency becomes more. So I think we don't have a definite definition for a recurrent upper respiratory tract infections if it is serious. Okay, so you have told me 2 possibilities. Any other possibilities that you consider for this baby based on your history, which is now becoming more and more severe?
Another could be a complication of the viral infections itself. Like both adenovirus and measles virus can be predisposing to etiologic agents for bronchiectasis. So there could be a development of bronchiectasis in the child, which can cause a persistence of symptoms.
Bronchiectasis, post-infective bronchiectasis.
Post-infectious. Yes.
Okay, but that is very, very, it's not that at all common for this younger age group. Okay, right? This is mainly because I think you had some CT findings. Otherwise, okay, we'll discuss that when you discuss the clinical findings. Any other possibilities? You said so many negative points in the history pertaining
like immunodeficiency could also be a possibility in them. Even if it is confined to one system, there could be a possibility of immunodeficiency. And based on the age group,
think of an immunodeficiency. If you think of an immunodeficiency or consider an immunodeficiency, which one? It's a B cell or a T cell?
Considering the age group, madam, T cell is more common in this age group. B cell arises a bit later.
Why not B cell? Why did you say considering this age?
Madam, usually in the initial 6 months, there will be protection from the transfer of maternal antibodies. Okay. So usually after 6 months, B cell is.
At all, you want to consider a T cell deficiency.
T cell deficiency.
But that is not high up in the list. Why? What is the point? Again, this is a strong point against considering an immunodeficiency here. What is the point against?
Ma'am, there is no involvement in any other systems.
Yeah, it's mainly the respiratory, no other system. What do you mean by which other system and which manifestations you think of a T cell deficiency?
Madam, recurrent episodes of oral thrush can be a possibility. Mucocutaneous candidiasis can be possibility. Then tuberculosis.
Suppose this baby, 6 month, hardly 7 month. A 6 month or 5-6-month-old baby can also thrush normally, especially if the baby is bottle fed and the baby has received so many antibiotics. Just the presence of thrush alone does not make you the possibility or give you the possibility of a T cell. Got it?
Yes.
Persistent thrush after the age of 6 months generally indicates an immune. But before that, especially a baby who is bottle fed and the baby who has received multiple antibiotics, that babies also can have thrush. Okay. But what are the other systems involved generally if it's a T cell or a B cell?
Skin manifestations can be common.
Yeah. Then
abscesses can be present.
Skin abscesses, that's what you said. Then
ear discharge can be a common presentation. Otitis, recurrent otitis media.
Okay. Diarrhea, GIT involvement, recurrent diarrhea, infections with unusual organisms, all these are quite common. So just because here it's confined to the pulmonary respiratory system alone, so that I think that immunodeficiency diagnosis has to come down much, much lower indices. So what you're discussing is mainly a congenital immunodeficiency. Do you want to consider the possibility of an acquired immunodeficiency, HIV? Is it a possibility?
Yes, madam. Could be possible.
Could be possible. What are the point against? What are the usual presentation? Baby is born to an HIV positive mother. When does it manifest generally? What are the 3 modes of transmission?
One is the perinatal itself, perinatal mode of transmission.
No, the baby gets exposed to a mother with HIV positive during the perinatal period. Now treatment given. What are the 3 types of manifestations? Well, if you know that, whether you can consider this as an HIV, the baby is manifesting at the age of 2 months or even 4 months.
A generalized lymphadenopathy.
No, my question is, can this 6-month or 4-month-old baby have? What is the commonest presentation? No, there are 3 types. One is a rapid transmission. One is a moderate. The other is a delayed, right? If it's a very rapid transmission, the baby can become symptomatic. That is, depends on the maternal viral load and the severity of the baby. Sometimes the baby can manifest with symptoms even during the first year itself, so that they succumb usually by 1 year. But majority of the children, that's hardly around 20%, but majority of the children will have something a moderate, means they usually manifest by around 3 to 4 years and they full-fledged symptoms like that. Then some again, a smaller proportion can start developing their symptoms after the age of 10 years. It's just equivalent to that of an adult. So what I'm trying to say is that this younger age, it's not that common, though it very rarely can occur. So that also you can consider, but investigation can do, but as low priority. Okay, then what else?
Madam, then based on the history, it could be a congenital lung malformation also, which is having a persistence of symptoms.
Malformations like
one could be congenital pulmonary airway malformation, CPAP. Then the other could be sequestrations.
Okay. So that also you have to consider because the baby started manifesting much very young early. Okay, right. Yes. Then that's all. You have been telling so many negative points in the history.
So congenital heart disease could be a possibility, madam. But then,
but again, your history does not point to a history. Nothing is there to point. Okay, the last we can roll out a CHD. Much before than that. You said so many. Do you want to consider the possibility of cystic fibrosis from the history?
Yes, madam. Cystic fibrosis.
Why don't you say that?
It could also be a possibility.
But again, what is the point against?
Point against is there was no in the perinatal history there was no delay in the passage of meconium or any sort of meconium obstruction, and also the child is having no other complaints like GI, loose stools or steatorrhea.
GI complaint is not there, but still we can say it initially manifests with a recurrent respiratory, and only as age advances they'll go for the GIP. So that also we can keep that in mind. Any other possibility? Again, you said something else.
Primary ciliary dyskinesia could also be a possibility.
Yeah, that's another possibility. Again, there are some points again, but history-wise, that whenever a child is brought with a recurrent respiratory infection, like what is the point against here from the history?
For which one? Primary ciliary dyskinesia.
Is there any point against to consider primary ciliary dyskinesia here in this baby?
Other systems involvement.
Or just say, what are the usual manifestations of a PCD?
Usually there will be presence of rhinosinusitis, madam. Persistent rhinosinusitis.
The baby starts having this discharge from day 1. The baby starts coughing from day 1 or 2, and with a recurrent
ear infections.
Otitis. So that's all the May. Then comes the pneumonias and all. So some point against, but still, if you want to investigate, definitely you have to investigate for PCD also. Then one more from your history. You have investigated. Do you want to consider the possibility of a TB?
Yes, ma'am. Currently, considering the high incidence of TB in India, it should also be a possibility. And also,
do you think because of that?
And also, no, and in this case, contact with history of TB in the grandmother, clinically diagnosed.
Because there is a history of a TB in the grandmother, which we are not very 100% sure, but still there is a possibility. But in that case, you have to go in depth into the history of the illness of the grandmother as well as the mother, also. Is the mother anyway symptomatic?
No, madam. The mother, I asked for any recurrent persistence of cough or any fever. The mother did not complain, and also based on the build, like mother looks fairly built, and we also calculated the BMI of the mother. Presenting later.
Okay. And also the baby manifesting from 2 months of age, it's very unlikely. Also that you have to take it as after the measles or something. So that's a remote possibility. Again, it's not a very strong point because we are not very sure. But still, as you said, because the TB being so rampant and even a vague history of contact, I think we have to rule out the possibility of a tuberculosis also, right? So from the history itself, we have so many differential diagnoses. One is BOOP, bronchiolitis obliterans, because there's a history of an adenovirus. Then we have to consider the possibility of an aspiration syndromes and swallowing dysfunction, especially because of the worsening related to the feeds.
Yes, ma'am.
Then immunodeficiency that comes as last in the list. Much higher above, you have to consider the congenital anomalies. And of course, you have to rule out a cystic fibrosis, primary ciliary dyskinesia, and then TB. Okay, putting that into your differential diagnosis from the history, I think you can go for the examination.
Okay.
Go ahead.
Moving on to the examination, general examination, the child was alert, dyspneic. There is no pallor, icterus, cyanosis. There was no clubbing, no presacral edema, and no generalized lymphadenopathy. Vitals, pulse was 120 per minute rate, regular rhythm, normal volume and character. And the peripheral pulses were bilaterally felt equally. Blood pressure was 84 bar 54 millimeters of mercury measured in the left upper arm. Respiratory rate was 56 per minute, abdominothoracic type, and the work of breathing was increased, and there was no evidence of any paradoxical breathing. Temperature was 98.6 degree Fahrenheit, and the SpO2 was 95% on room.
Your comments, Akash, just go back. No pallor, no icterus, no cyanosis. Suppose there's a clubbing. Suppose you got some clubbing here for this baby. What are the possibilities then you will consider?
Madam, based on our differentials, cystic fibrosis can be a cause for clubbing.
Okay.
Any suppurative lung diseases for a prolonged duration can cause clubbing. So that could be a possibility.
One more.
If
it is an interstitial lung disease also, post-viral, that can also produce a clubbing. Why did you say presacral edema?
Madam, we look for dependent edema. So since the baby was mainly in the supine position, we look for dependent edema in the presacral area.
This baby is always lying still. Okay, right. Go ahead. If there is a generalized lymphadenopathy, what are the point two?
HIV could be a possibility.
Okay.
Then TB also could be a possibility. Tuberculosis.
Okay, carry on. And you said, what about the respiratory rate? 56 per minute. Increase. Okay, go ahead.
Head to foot examination. Head size appears normal. There was plagiocephaly on the right side.
What do you mean by that? Can you explain what is that plagiocephaly?
There will be asymmetric flattening of the occiput, madam, on one side.
What do you think is the reason?
Persistent positioning of the baby with head lying to one side can be a cause.
Okay, go ahead. Then
anterior fontanelle was open, size 1x1 centimeter. Posterior fontanelle closed. Hair appears normal. Flax sign was negative. Seborrhea present over the scalp.
Do you expect the flax sign to be positive here? What do you mean by flax sign?
There will be alternating bands of light and dark color in the hair.
When do you get it?
Usually in malnutrition cases, we can get flax sign positive.
Which phase of the malnutrition? You get a what? Colorless or a local or depigmented hair when the child has got a malnutrition. Only when you treat malnutrition and the child starts recovering, you get a normal color. So only when you start treatment with adequate protein and all, you get the flax sign, not during the phase of an acute. So that is not a very relevant point here. Okay.
Okay.
Then seborrhea. Okay, seborrhea. Can you correlate this with any condition where the child manifests with a recurrent respiratory infection and sort of a seborrhea?
Madam, Langerhans cell histiocytosis could be
That's a very, very far-fetched. Other than that, suppose there
any
is
for
some
immuno
dermatitis over the skin also generalized.
immunodeficiency disorders.
Which one?
Viscotalid syndrome can be.
Yeah, Viscotalid syndrome is a recurrent infection with seborrheic dermatitis and
Thrombocytopenia.
thrombocytopenia. So it was there only over the scalp, not over the other parts?
Yes, madam. It was not present any other part of it.
Okay. Okay, continue.
Eyes, there is no evidence of Bitot spots. Oral cavity, no evidence of cheilitis or glossitis. No oral thrush, no cleft palate, bilateral tonsils present. No
Okay.
evidence of
That's very important to mention about the oral thrush, because we already said if the presence of a thrush indicate a possibility of a T-cell defect. Cleft palate also you have to see very carefully. No, on your examination, if the cleft palate is not visible, there is no visible cleft palate, do you want to do any other test? What I'm trying to say that if the cleft palate is not very obvious, can you think of some condition? You may miss that. Yeah, yes.
Submucous cleft palate.
Yeah, there may be the possibility of a submucous cleft palate, which you can find out only by palpating. Otherwise, you may miss that. So you do that and find out, because that may also contribute to recurrent aspiration. Then the presence of a you said bilateral tonsils plus. Are you trying to convey something?
Madam, absence of tonsils could be an indicator for immunodeficiency. So I wanted to look specifically for the presence of tonsils.
Yeah. So any child with recurrent respiratory infection, especially a little more older, you have to look for lymph nodes as well as the tonsils. So in which immunodeficiency the tonsils are absent and lymph nodes are absent or smaller in size? T-cell or B-cell?
Usually T-cell defect there will be.
It's a B-cell.
B-cell.
B-cell deficiency, lymph nodes may not be there and the tonsils may not be there. But this baby, hardly 7-month-old baby, even the tonsils are quite smaller in size. Even the lymph nodes are smaller in size. So it may be difficult, but older child, it may be much more easier, right?
Yes.
Okay. Then why did you say micrognathia or retrognathia?
Madam, micrognathia and retrognathia can itself be a risk for aspiration of feeds in this child, in a baby. So we specifically look for the syndromic conditions like Pierre-Robin sequence.
Are you bothered only about the Pierre-Robin syndrome? Any other dysmorphic, any other condition with a dysmorphic facies and the child with a recurrent respiratory tract infection?
Treacher-Collins.
Much more common rather than the Treacher-Collins. We think of an immunodeficiency.
A Dijorg syndrome can also be.
What is abnormality? What abnormality is there in the facies? Just one or two.
There can be
Yes. A fish
there are prominent eyes with maxillary hypoplasia and supraorbital.
Okay, it's almost like antimugaloid slant and then the fish mouth appearance and all. So we get a dysmorphic facies with a recurrent respiratory infection, younger age, mainly a DGOG, and older children, even you can say Downs, but it does not come under, or it's not very prevalent here. Okay, go ahead. The next. Continue.
BCG scar present. No chest wall anomalies. No Harrison sulcus or swelling.
What do you mean by which chest wall anomalies you expect?
Madam, any evidence of rectus carinatum or
okay, small baby with increased work of breathing.
Work of breathing persistently can cause hyperinflation.
What do you mean by Harrison sulcus?
It is an increased hollowing of the rib space at the site of attachment of the diaphragm, madam, which can be usually seen in babies with prolonged respiratory tract infections.
Yeah, any chronic respiratory problem or any chronic cardiac problem, you can have a Harrison sulcus. Okay, right. Why did you say no widening of the wrist?
Madam, like based on the history, there was inadequate weight gain. So to look for vitamin deficiencies associated with malnutrition.
How do you get the widening of the wrist?
In vitamin D deficiency, usually when there is
How do you get? Only when the
there
child or
is
the
this
baby bears
treated
weight on the hands.
Oh,
So you said there is a delay.
yes.
You said there is a delay in the motor milestones, right? The child is not. Yes, sir. Srinivasan sir, you're
Yeah,
muted.
question.
You're
Vitamin
muted.
deficiency in younger children will be more of a head enlargement and this thing because fontanelle is head circumference increasing. So widening of wrist will occur later, a little later, not
Yeah, that's
before
all.
1 year.
So only when the
So
baby
there
is
will be
developing
more
is normal.
crossbone appearance, etc., because
Yeah.
rapid expansion.
Okay.
And
Got
one
it.
more point I wanted to make earlier, you don't mind, madam?
Yes,
So
sir.
about tonsils, usually thymus will be very big at this age, and tonsils may not be so prominent. It may be present,
Okay.
but not this thing.
Okay, sir. Thymus only when we take an X-ray, they'll be able to. Okay. Okay, right. So the wrist, widening of the wrist, you should not say in a very young baby, right? Our common when they bear weight and only when they crawl and they creep, only that widening because of the softening of the bones. When bear weight on that bone, it will get a widened. Got it? Okay.
Okay.
Right. No rash over the body. What is the rationale for that statement?
Madam, this also in association with the malnutrition, any abnormal skin manifestations of the malnutrition they look for.
Okay.
And
right.
also the skin lesions, particularly to look for immunodeficiency.
Why did you say no kyphoscoliosis for such young baby who is not yet started turning over?
Scoliosis could have a limitation in the lung functions. So
scoliosis can have limitation, but again, which condition you can have such a younger age group? Okay, next slide.
Coming to anthropometry, the weight for age, observed value was 5.5 kilogram against an expected of 8.5 kilogram. It belongs to less than -3 standard deviation. There is severe underweight. Length for age is 67 centimeter against an expected of 70 centimeter between 0 to -2 standard deviation. Head circumference is 42 centimeter against an expected of 44.5 centimeter.
Yes. Can you summarize and tell what is the relevant point here?
Madam,
interpretation?
The weight for length is less than -3 standard deviation, and the chest mid-upper arm circumference is 11 centimeter, which fits in the criteria of severe acute malnutrition.
Hello.
So, hello. Hello, madam. Can you hear me?
I had a break. Okay, right. Now it's okay.
Madam, the weight for length is
the weight is the most important thing affected parameter, and the height or the length is not that affect. No, there is only a 3 centimeter difference.
Yes.
So what does it mean? It's mainly an acute onset.
Acute.
Right.
Acute onset.
It's an acute comparatively 2 to 3 months duration of illness only. So that means it's a severe acute malnutrition where the length is not affected and evidenced by a low mid-upper arm circumference also. Right. Go ahead. The next slide.
Madam, this is the growth chart plotting of
we can skip
the weight.
That. We are definitely said. Skip that.
Developmental assessment. Gross motor.
Do you want to tell us anything other than your development history? Already we had heard. Anything else after your assessment?
Madam, the gross motor is having a delay of 67. The developmental quotient is 66%. Others are 80%. So, as based on the history itself, there is a gross motor delay. No other specific new.
Okay. And this gross motor delay, can you explain that? Do you think it's due to some neurological illness or is it due to his?
Madam, there is malnutrition, so there is reduced muscle mass, which itself can be a cause for the gross motor delay.
And also because the child is spending much of his lifetime over this in the hospital.
Yes.
Sick always, requiring oxygen in different modes. So you can explain that. Okay, right. Go ahead. Then.
Moving on to the respiratory system examination. Upper respiratory tract, nasal mucosa, there is presence of mucoid secretions, no polyps.
Why did you say polyps? Why do you want to look for polyps?
In cystic fibrosis, there can be nasal polyps in approximately 20% of the cases. So I look for.
So all you have to, it's mandatory for you to look for polyps in all children presenting with recurrent respiratory tract infection. Okay,
Yes.
go ahead.
Throat, bilateral tonsils not enlarged, no pus, and posterior pharyngeal wall not congested. There is no ear discharge bilaterally.
Okay, don't say not enlarged and all because hardly 5-month-old baby, no?
Okay.
Which is the maximum which is the age group or range of the age group where you get a maximum lymphoid growth so that we get an enlarged tonsils?
7 to 10.
Physiologically. 4 to 8.
5. 4 to 8.
4 to 8 years. So normally we don't expect an enlarged tonsils here. If you want to think of a possibility of a B cell deficiency, the tonsils are absent. So these enlarged tonsils do not convey any meaning, right?
Okay.
Okay, right. No ear discharge. Okay, that also you have to look for. Okay, go ahead.
Lower respiratory tract on inspection. Chest movements appear equal on both sides. Apex beat not visualized. No pectus excavatum or carinatum. And work of breathing, there was presence of subcostal and intercostal retractions in that. This is a video of the child's work of breathing.
So what are you trying to convey with this?
Madam, there is presence of work of breathing in the form of subcostal and intercostal retractions, which points to a small airway disease as well as involvement of lung parenchyma.
There's a significant respiratory distress.
Increase
as evidenced by the increased work of breathing. Is there any excessive hair growth for this baby? Hair growth, hypertrichosis. I can't make out by this, but still when you examine?
No, madam.
Okay, right. Go ahead.
Palpation, chest movements bilaterally symmetric. Chest movements appeared equal over supraclavicular, infraclavicular, mammary, inframammary, and infrascapular areas. Apex beat was in the left fourth intercostal space, just at the midclavicular line. And tactile fremitus over the supraclavicular, infraclavicular, mammary, inframammary, infraaxillary, interscapular, and infrascapular felt bilaterally equal.
How did you examine for a tactile vocal fremitus for this?
Madam, like on initial examination, the baby was crying. So I palpated the crying episodes.
Okay. Because it's very, very difficult to look for a vocal fremitus for even an older children. Okay, right? Then?
Percussion, there was impaired resonance over the bilateral infrascapular area and normal resonance heard over bilateral infraclavicular, mammary, inframammary, infraaxillary, interscapular, and infrascapular areas. On auscultation, breath sounds heard bilaterally equal. Normal vesicular breath sounds with crepitations heard bilaterally in all the areas and end expiratory wheeze heard bilaterally in all the areas. And vocal resonance was also equal in all the areas.
What type of crepitation? Was it a coarse crepitation or a fine crepitations?
Madam, I perceived it to be like coarse crepitations. It was not like fine velcro.
What is there any relevance if you say mainly you're hearing a coarse crepitations and hearing a fine creps?
Madam,
how do you
coarse,
get?
When coarse crepitations usually pertaining to this case, bronchiectasis is a cause for coarse crepitations.
Generally, when do you get a coarse crepitations? How do you get?
When there is a opening up, snapping open of the airways during inspiration.
When the air passes through the secretions,
Secretions.
In an airway, like a bronchi mainly. So that is why in bronchiectasis you get coarse crepitation, coarse lateral crepitations, but you get an even bronchitis, right? When you have an edema secretion in the bronchi, then also the air passes, you get a coarse crepitations. So whereas in the case of alveolar involvement or a parenchymal involvement, just like an opening as in the case of a pulmonary edema and all, you get a fine crepitation.
Fine crepitation.
Parenchymal involvement, you get a fine. Here you are getting mainly coarse means it's mainly the airway. So only if there is an airway involvement, you may not get this much of increased work of breathing, retractions and all. So it has to be a mixture of both fine and coarse crepitation. That's what I think. Right. Okay, good. It is difficult to make it out, but still. If you say only coarse, that means it's only an airway involvement. Okay, go ahead. And wheeze also heard. Your wheeze also.
Yes, madam. And expiratory wheeze was.
Okay. And this crepitations were heard uniformly in all areas, or was it predominantly heard in particular certain segment?
Mainly in the bilateral, if at all, in the bilateral infrascapular region, it was somewhat thought to be prominent, madam, but couldn't make it out the difference clearly.
Posteriorly basal areas.
Posterior basal areas.
Means most of a lower limb. Okay, right.
Our other systems examination, cardiovascular system, apex beat in the left fourth
Okay,
intercostal
hold it.
space.
Cardiovascular, in this type of cases, cardiovascular examination, what all things you look for?
Madam,
One.
any evidence of cardiomegaly?
No. Okay. Any evidence of cardiomegaly or any murmur which may indicate which cardiac condition causes a frequent respiratory tract infection?
A high volume cardiac output states, madam. VST,
You
PDA.
say left to right shunts.
Left to right.
You say left to right shunts, right? Why do you get the increased incidence of recurrent respiratory tract infections in a child with CHT and left to right shunt? What is the physiology?
Madam, in left to right shunts, there can be increased passage of increase in the pulmonary circulation and flow to the pulmonary areas, which can cause a congestion and can be a risk factor for harboring
So
the
you
organs.
look for any murmur which may suggest a left to right shunt. That is the most common cause. Any other particularly you look for in this child?
Any hepatomegaly?
Cardiac.
Increase in JVP in this?
No. You had discussed that in your differential diagnosis in the history. And so many negative points also you had said. Yes.
Dijorg syndrome?
No. In primary ciliary dyskinesia, what is the cardiac finding?
Situs inversus can be
dextrocardia. So dextrocardia.
The apex beat can be present on the right
so
side.
dextrocardia or even a situs, total situs inversus. Why? What is basically happening in a primary ciliary dyskinesia? There is an abnormality of the ciliary movements, right?
Yes.
Ciliary movements are defective, so it results in a chronic ear infection, chronic sinusitis, like chest infection. So like that, developmentally, the cilia is not moving properly. It may interfere with the movement of the cardiac also during that early stage. So it may result in a dextrocardia situs inversus. The same thing may result in, say, for example, lack of sperms in the and male infertility. So all this can happen. So definitely you have to look for a dextrocardia in this child. Go ahead. Then next.
Coming to the CNS examination, baby was alert.
Everything is normal, no?
Yes, ma'am. No.
Okay.
Per abdomen was soft, not distended. The liver was palpable 2.5 centimeter below the right costal margin, which was non-tender, soft in consistency, smooth surface, rounded margin. The liver span was 5 centimeter. Spleen was not palpable and prop space was present.
So that also normal. GIT is also no hepatosplenomegaly. 2.5 centimeter with a span of 5 is, I think, can consider as a normal. What is a normal liver span at this age group?
4 to 5 centimeter can be.
Okay, so that means there is no hepatomegaly. There is no organomegaly.
Yes.
Okay, go ahead.
So based on the history and the examination.
This is not the diagnosis summary. This is the diagnosis?
Summary.
Okay, what is the diagnosis? Summarizing from the, you have already summarized your history. Anything else you want to summarize from your or any other? Have you become wiser after your complete physical examination so that you can add on to your diagnosis? Or now you want to prioritize your list? Okay, I think gross motor delay, we discussed that's not that significant, that you can skip. Immunized for age is not a diagnosis. So this child has got a recurrent pneumonia with severe acute malnutrition, right?
Yes.
Now, what are the possibilities? That is the one.
Madam, after the examination, I would like to consider congenital lung malformations lower in the list because there was no focal findings during respiratory system examination.
So congenital malformations lower in the list. You want to consider BOOP still? Means bronchiolitis obliterans?
Yes, madam, could be a possibility because there is presence scattered.
Okay, that you can consider. Aspiration syndromes like tracheoesophageal fistula?
tracheoesophageal fistula could still be a possibility. In that, especially the H type can be missed, ma'am. So
Okay,
that could
so
be
we
a
can keep the BOOP as well as the aspiration syndromes, bronchiectasis. Yes.
bronchiectasis could be a possibility, madam.
Okay. Immunodeficiency.
That also lower in the list, madam, because in
Much
head to
more
foot
lower,
examination.
I think just for the sake of completion investigation, you can consider. What about cystic fibrosis?
The examination wise, only the
Unlikely, right?
respiratory system
There's
is
no
involved.
organomegaly. Okay, right. PCD, primary
PCD
ciliary dyskinesia also
also lower in the list.
is also lower in the list. If you have facilities, you can investigate. What about TB?
TB could still, but then in considering endobronchial TB, then there should be localized findings, madam.
Okay, so
other than
based
that,
on your this thing, I think what are the investigations that you can do, you have to do, and what are the available?
madam, firstly, considering the possibility of bronchiolitis obliterans, we could do a CT scan, madam, which could.
No, first and foremost, you take an X-ray, right? X-rays. Go CT a little more later. We'll go with the primary investigations. You have evidence of an X-ray? Or just okay, just go with the list. So you want to consider an anomaly like a TF, tracheoesophageal fistula, GERD, okay? Congenital lung abnormalities, cystic fibrosis, immunodeficiency. So for me, this BOOP has to come a little more higher up.
Okay.
Immunodeficiency has to come a little more lower down. And then swallowing dysfunction. I think because there is a worsening, I think you have to consider the possibility of a dysfunction of swallowing. And as well as because of the episodic worsening, you have to consider the possibility of an airway malacia as well. Airway malacia means either a tracheomalacia or a bronchomalacia, where they are prone for recurrent aspirations and recurrent hospitalizations. So I think that also you have to consider. But only thing is that we can confirm it only by the investigations, detailed investigations. Okay, go for the investigations.
These were the blood investigations.
Basically, what are you trying to convey? You are trying to rule out an immunological disorder by doing CBC. So what are things you look for?
Specifically, we should look for the total lymphocyte count.
So from this picture, is there any absolute lymphopenia?
No, madam, there is no lymphopenia.
There is no absolute lymphopenia. There is no absolute neutropenia. So this CBC is not suggestive of a
immunodeficiency.
Especially T cell. Okay, just forget. Go ahead.
These were the series of X-rays which were taken during the course of hospital stay of the child.
So, looking at this X-ray, what you can rule out is?
Congenital airway malformation is lower down the list. Unlikely because there are no specific focal findings.
There is a presence of a thymus. The thymus is definitely well lineated.
Yes,
that means the T cell, again, I think you can almost rule out a T cell deficiency. But I think bilateral, the second X-ray is really worsened with a bilateral almost nodular type, right?
Yes, ma'am.
Okay, right, go ahead. Something worsening. The fourth one, again, there is a bilateral, both the cardiac margins are obliterated and right upper zone is also, I think, fourth and fifth, right upper zone is a little more hazy.
Yes, ma'am. Yes, ma'am.
And the left lower also, the left lower and middle. That is what I can make out. Okay, right then. With this, we cannot say a structural defect because it's a multi-sited.
Yes,
if sequestration or something else, I think it has to be same site. So that I think you can almost rule out, but we cannot rule out the other possibilities like BOOP, aspiration syndromes. Pulmonary TB, can you rule out by this? You want to consider TB by looking at this X-ray?
Madam, TB usually involves the right middle lobe. There will be persistence of X-ray findings, and also, but then there is presence of hilar lymph nodes also could be
Okay,
a
that's
point.
all classical initial stages, but in a young baby with a severe, means where the baby is not able to localize this, you can still have a disseminated tuberculosis with extensive lung involvement, you can have. Okay, right, go ahead.
This was
You
the
can
initial
just say
HRC.
the salient points.
This was the initial HRCT thorax which was taken during the third admission, and it showed consolidation with air bronchograms involving the bilateral lung fields, predominantly the posterior segment of right upper lobe, right middle lobe, and medial basal segment of right lower lobe, with apical segment of left upper lobe and superior segment of left lower lobe involvement.
So almost all the lobes, right? Both
All the
sides.
lobes.
Okay, that is the initial consolidation. Okay, go ahead.
Yes, ma'am. This was the CECT thorax, which was an oral plus oral contrast thorax, which was taken, which showed bronchiectasis and air trapping changes noted involving the posterior segment of right upper lobe and superior segment of both lower lobes, and subsegmental atelectasis of right middle lobe, lingula, with no evidence of any tracheoesophageal fistula.
So the only thing you could rule out is a TEF, right? Okay, right, go ahead.
A TEF, yes, this shows the widening of the airway and also involvement of the posterior segment of the superior lobe, and this shows the bilateral.
You mean to say some bronchiectatic changes?
Yes, ma'am. Here
Okay.
there is some widening of airways involving the bilateral lower lobes and also the superior lobe on the right side.
Okay, right.
This is it's a video of the cross-sectional CECT. Here you can see the superior lobe involvement.
Can point it.
Please. I'll just play it again.
Pointer.
This is the superior upper lobe involvement, and as we go down, this is the bilateral lower lobe involvement, superior segment of the lower lobe involvement.
Okay.
Next. So this was the oral contrast. So this was the oral contrast which was done. So this is the contrast that is present inside the trachea. However, over the full course, there is no connection which is being seen between the or any spillage of the contrast into the from the esophagus into the trachea. I'll just play that once more.
It's okay. It's okay. It's okay. There's no evidence of tracheoesophageal fistula. Right.
Yes,
Continue. Continue with the rest because I think the time is also 9 almost. So.
This shows the oral contrast with no spillage over there.
Okay, right. Definitely we can say there is no evidence of a tracheoesophageal fistula, right?
Yes, ma'am.
Okay, right. Go ahead, continue with your presentation. So now, why do you want to these investigations? Barium swallow and cine esophagogram?
Based on the aspiration, madam, actually we discussed with the radiologist, so they said that still H-type fistula can be a possibility, which can be missed in the oral contrast CT. So to confirm that, I would like to do the barium swallow and cine esophagogram.
Okay, again for ruling out a GRD also.
GRD also. Yes.
Gastroesophageal reflux disease also, you can do the esophageal pH monitoring. Okay, right.
Sweat chloride testing is to diagnose, to look for cystic fibrosis, madam.
Okay, right. I think rather than the sweat chloride testing, nowadays I think it's better that we go for genetic studies.
Genetic studies.
Genetic studies, better that. Okay, then?
Then bronchoscopy with a bronchoalveolar lavage could be helpful in this case, madam.
Did you do that?
Actually, it has not been done.
Bronchoscopy done for this child or you're planning?
Yes, planning to do.
Akash?
Yeah. Madam, can you hear me? Hello? Hello?
Stuck ആയിട്ട് തോന്നുന്നു. റെഡി ആവും. ഷോദ സാർ മ്യൂട്ടാണ്.
മാഡത്തിനെ വിളിച്ചു നോക്കണം. മാഡം ഔട്ടായി തോന്നുന്നു. Okay, Agarsh, both of you did very well. Madam discussed everything, and Agarsh also presented very well. Madam, once she is back, I just and the everything systematically discussed, because when you're getting a recurrent respiratory problems in the environmental thing, like the smoking is there, overcrowding, where everything else is normal, that is ruled out. Then the possibility of a generalized recurrent infections is ruled out because it's only one system.
Yes.
So we have come back to the respiratory system problem and excluded the respiratory immunodeficiency problem. Then the pulmonology plus the sinus and ear, the sinus and ear combination with the pulmonary possibility of the cystic fibrosis, the ciliary dyskinesia, that also is ruled out. So you have narrowed down the possibility to the pulmonary part. There, in the newborn period up to 6 weeks, it was not there. So the possibility of many of the conditions of malformation are still out. So cardiac problem is considered, but the congestive failure is not there. But what you didn't mention was, in between the episodes, was he gaining weight or symptomatic? That is one thing to be mentioned. And one very important thing is, what about during the tube feeding, whether the tube feeding period afforded some relaxation of this thing? Because upper area, the aspiration will be protected by the tube feeding. Like H type of fistula, recurrent respiratory infection will not occur. So that is the point. We need to go back to the history. In all these cases, the feeding should be demonstrated in front of you. During the feeding, if there is choking, that means there is an upper malformation, and lower malformation, the aspiration will be some other time. So these are the important thing. And always, what is the method of feeding that you need to ask? Baby who is fed in the lap. So method of feeding is important. In between episodes, what is the symptoms is important. Observe the feeding is important. And in the family history, one thing you forgot was that Madam already stressed on that. The infertility.
Madam,
okay, Madam, you go ahead.
Sorry, I think something went wrong. Okay, Purushothaman, if I taken up.
You are not there, Madam. Okay, you continue, Madam.
Okay, so where were you, Akash? Bronchoscopy, bell, lung biopsy. Okay, right.
Yes.
So, as I think taking back from Purushothaman, then definitely we have to roll for GRD, and much more important is some swallowing dysfunction also that you have to test for. How are you going to do that?
Swallowing study, milk.
Yeah, we have a video that is scintigraphies, video-assisted scintigraphies. You can just make the child swallow and see whether there is any aspiration going on. And what I suggest is definitely this child needs a flexible bronchoscopy and a ball. From bronchoscopy, you can rule out so many things. You can do the ball and give it for culture. Tuberculosis also, you can rule it out by definitely just by giving a gastric aspirate, you know, the sensitivity is not that high. And definitely bronchoscopy, we can rule out airway malicias also. And definitely a video-assisted esophago, that is swallowing studies also. I think these are the things now that we have to do. Especially, I would like to share with you one experience. We had an almost similar child with a recurrent aspiration, recurrent pneumonias, finally, all the investigations, including CT, as almost like this, even cystic fibrosis workup, everything has been done. And then finally, we sent the child for a flexible bronchoscopy, and which detected a bronchomalacia, tracheomalacia, a moderate degree of tracheomalacia that can lead on to all these, because there is a larger one. So there is a stagnation of secretions and very thick secretions which can get aspirated. So what we are doing is actually, because the child had recurrent V's, we were managing the child with a recurrent bronchodilators. Are you giving, or do you have this child also required, or are you receiving a lot of bronchodilators like salbutamol nebulization?
Yes, madam. Currently also the child is being given salbutamol
I
nebulization.
think you can just, there is not, even a SMIT is of B. See, there's a tracheomalacia. What happens is that if you give a bronchodilator, especially beta-2 agonist, can give a bronchodilation, it further reduces the muscle tone, it worsens the tracheomalacia. It worsens that airway malacia, so it can actually aggravate the condition. So now, better you nebulize with some secretion, that is clearing agents, like to thin down the secretions like ipratropium or even a saline, and then send the child for a bronchoscopy. I think that would be a better. Okay, then how do you manage? What is the next slide?
Management, the plan of.
So the management, of course, you have to manage what the child is having now.
Yes,
the child is having a respiratory infection, you treat. If the child needs respiratory support, as evidenced by the oxygen and IV, give that. Take care of the nutrition, take care of the secretions, and then, of course, depending on the cause. So that's what I said, we have to have a definite diagnosis by doing all these investigations. But if nothing is coming out, I think even you can try with an empirical ATT. After seeing the results with the lung biopsy of the grandmother, do a BAL, do a bronchoscopy BAL, and send the samples for tuberculosis for this baby as well.
Okay.
Okay. Purushothaman, take over. What is your, I missed your.
Oh, one thing I remember distinctly was when we were working under Noel Narayan sir in 1997, there was a case of X type of fistula. Again, we were in trouble, and we could demonstrate it from the SUT hospital with the cine esophageal. I still remember that.
Balakrishnan sir did the singing.
Exactly. And the importance is that the CT cannot rule out actually this thing, because in the lying position, you may not get the dye entering into the trachea. So cine esophagogram is very, very important. That can only demonstrate. This one of the possibility in this case remaining is a malformation like the upper airway aspiration, very likely. The immunological problem, one of the entities already discussed, this Saboria is another rare entity, is the C5 complement. That's called Lener's disease, Leiner. That's a rare theoretical possibility only. So that is one thing to be considered. Another thing is in the when you're analyzing, and madam ruled out many of the things, and what remains is upper airway. Some of these situations, there are rare possibility other than the ciliary and cystic fibrosis, air possibility of a tracheobronchomegaly, few of the malformations like Morier-Kuhn syndrome, there is a
William
Campbell syndrome, and additional malformations of the airway. They're all rarer possibilities, especially when they're leading on to a bronchiectasis situation. And
that's what I said. We had one case of the tracheomalacia, almost like this picture. That baby was going in for a recurrent life-threatening events also. So definitely bronchoscopy, flexible bronchoscopy. I know that many of our medical colleges do not have a facility for a flexible bronchoscopy for young babies. I think we had sent that baby to Amrita, where Sajid Keshav had done the bronchoscopy. He is an intensivist come pediatric pulmonologist. Maybe you can, if can refer for a bronchoscopy, then that may give you the final diagnosis. You can get the BAL also.
Okay.
Adarsh, can you stop sharing?
Absence of symptoms in the first 2 months, is it a point against H type of fistula?
No. It's type of fistula can manifest at any age. That's not a point against.
Madam, actually, we tried to do that flexible bronchoscopy. Our pulmonary medicine people are not willing for.
Darling, it's true because they are not familiar. They don't have that smaller size of
Yeah,
even Trivandrum, we didn't have even our Trivandrum pulmonologists, but they're not very confident also. We can't blame because so that is why I discussed with Sajit and sent the patient there, and then definitely there's a dramatic or remarkable improvement with the management. The child is more or less doing well now.
This tracheomalacia, will it be evident in CT?
CT may be, but only in adults, but not in the younger chest. It may not be. It may not be. Definitely, it's only by the bronchoscopy.
And also they are not that affordable people. That is the limiting factor.
That is the limiting factor. We can, he will not even admit or for a day or something. Maybe you can directly call him and talk to him, find out. Reduce cost admission preparation. But definitely this child needs a bronchoscopy. It's better that you do.
ഇപ്പം തൽക്കാലം വീട്ടിൽ വിട്ടിരിക്കുകയാണ്. ഇന്നലെ വിട്ടു.
ആണോ? ഓക്കെ.
തിരിച്ച് അവൻ ആ വീട് കണ്ടിട്ടില്ല. He is familiar with the hospital environment. Stealth അങ്ങനെയുള്ള കാര്യങ്ങളൊക്കെയാണ് അവന്റെ എന്താണ് choice actually.
Agarsha, in the measurement, I have just one point. You measure the mid-arm circumference once more. Because mid-arm circumference at newborn, in the newborn, it is 11 centimeters and it becomes 15 by 1 year. It becomes 15.9 by 5 years. So just 1 centimeter from 1 to 5. That is the basis of a mid-arm circumference. Use that. So there is a growth of 11 centimeter to 15 centimeter in the first year. Here, the weight gain is there, even though it was inadequate. 8.5 you said, but in an 8-year-old child, you don't expect 8.5 in our country. It will be somewhere around 7.5, 8 range. Here he's having 5.5. So that baby will have a mid-arm circumference a little higher than a newborn baby. A newborn baby's mid-arm circumference is 11. So your mid-arm circumference, I think it's wrong.
Okay.
Madam, very well.
Is almost normal.
You prepared very well. Very good presentation.
Yeah, Akash, very nice presentation. Well. And almost, I think, very well worked up also, darling.
And another doubt, madam, when here we are actually something like a PG examination scenario. So here, a lot of investigation details were given initially itself. Is it?
Exactly. Better to avoid the findings in the case presentation. So, in the examination,
we should have discussed the DD. I think almost history-wise, physical examination-wise, we discussed the DD and then like that. Okay. Discussion. Before that, okay, no.
Okay.
Okay, I think, shall we wind it up? Can we call it a day? Any comments?
It's a really nice discussion, ma'am.
Thank you, Mohandas. And it's a learning experience for me also.
Srinivasan sir, എന്തെങ്കിലും കൂട്ടി ചേർക്കാനുണ്ടോ?
Madam, I am reminded of sitting with her as her examiner, and she has been excellent. Yeah, and
I think we have been co-examiners for many times, sir.
Mauner-Kuhn syndrome and other syndromes. Yeah.
Thank you, sir.
Thank you, madam.
Keep us updated about the follow-up also, what happened, Akash. Okay, it's your responsibility.
Okay, ma'am. Thank you, ma'am.
Okay, then. Thank you, everyone.
Thank you, ma'am. Thank
for
you.
the opportunity also. Thank you, Mohandas.
Good night, all of you. Great day.
Good night.
Dasan, wind up ചെയ്യാം Dasan. പോയോ? അപ്പൊ ഡാർലി മാഡം ഒരു താങ്ക്സ് പറഞ്ഞോ? ദാസ് പോയിന്ന് തോന്നുന്നു.
പോയി എല്ലാരും ബൈ ബൈ പറഞ്ഞ് പോയതാണ്.
മാഡം ഒന്ന് താങ്ക്സ് പറഞ്ഞാൽ നിർത്താം വീൽ വൈൻഡ് അപ്പ്. അപ്പൊ ഓക്കെ എന്നാ
മാഡം ഞാൻ പറഞ്ഞേക്കാം.
സുരേഷ് പറഞ്ഞു.
On behalf of IAP Kottayam, I extend our thanks to our dear faculty for the day, Lalitha Kailas Madam, and also for all the senior faculty members on this forum, especially Purushothaman Sir, Mohandas Sir, and Thomas for conducting this program, and Darli Madam for being the mentor of this case, and for August for the wonderful presentation. Thanks a lot and good night, everyone. Thank you.
Thank you.